Wait a minute. Let me turn you up for me. I'm not going to mess with the settings. I'm just going to turn you up in my... Okay. Say something.
Hello.
Okay, I can hear you. Good. Good morning. Good morning. We made it. One more again.
Yeah,
Glad to be in the service one more time. How was your week?
it was busy.
Yeah.
I'm always doing something.
Sir. That's an understatement coming from you. That is an understatement. Yes, yes, yes. I'm trying to get my mic out the way. Uh-oh. I'm bringing it forward. Never mind. It just had to be there. Okay. Yeah.
I said, how about yours?
It was busy. Um, like you, all over the place. All over the place. Had to have some discussions with folks and conversate like who who you who are you talking to? I had to have some what they say in the office crucial conversations. Yes, we'll say it that way. I had some crucial conversations. So I had to channel my inner Tabitha Brown this week.
Oh,
And just have some nice crucial conversation. But for the most part, it was great. It was great. Happy Juneteenth. Happy Juneteenth.
yeah.
I wanted to I guess I was gonna wait till the church announcements, but I'll get I'll talk. Well, let me start the show and then we can get to the Juneteenth topic of the day. Welcome, welcome, welcome. Welcome everybody. Thanks for joining us. Um, you have joined us, and welcome to our Saturday morning tea, where we discuss health information, news, education, certification tips, entrepreneurship, the weather, the journey, the drama, the gatekeeping, the code shifting. We discuss it all. The revenue cycle at large. Don't forget as you come in to hit the thumbs up or like button to help us with engagement. Appreciate you on that. I'm Clarice Warner, the girl with the pearls, the founder and senior education director of the Professional Reimbursement Network, LLC, where coding education is key. And PRN is a healthcare compliance consultancy located in Cincinnati, Ohio, that specializes in revenue cycle and regulatory compliance and education. Now, let me ask you, yes, you. Do you know what it takes to be a certified marketable medical coder? And are you interested in that? Well, before I introduce my co host, let me share with you information on a free, yes, free 99 email course on the 5 steps to become a certified marketable medical coder. Are you interested in medical coding, but not sure where to start? And scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder. All right, all right. See, I always get caught up. I told you I do my research when I'm on these little tunes here. I have a whole little collection. Like, oh, let me see what works with what message. That's where I think the DJing piece come in. Oh goodness. So if you are interested and you're in Clubhouse on getting more information about the 5 steps to become a certified marketable medical coder, then you can click the link at the top of the screen. If you are joining us via YouTube, Facebook, and LinkedIn, you can check the video description or you can check for the video link in the description box. Just scroll down, it's down there. Trust and believe, it's down there. So joining me today is my co-host, Mr. Jesse, the registered trademark. You better put some respect on his name, the coding nurse. Sir, introduce yourself and tell the folks all about you.
Good morning, everybody. My name is Jesse. I live in Philadelphia, Pennsylvania. I have been a nurse for a very, very long time. During the pandemic, actually, I transitioned into HIM in 2014. During the pandemic in 2020, I created a company called The Coding Nurse. LLC, where I help nurses and other clinicians with clinical background transition into the wonderful world of HMA.
Oh, and isn't it a wonderful world?
It
I need to
is.
find something that say, "Oh, what a wonderful world." Ah, yes, yes, yes. All right. So how's things been going? How's all the do we have some do I need to play my church announcements now? Do you have a church announcement that you need to
I,
provide?
I really don't have any. It's just that I was busy this week because, well, actually, for the past 2 weeks, because I have two classes going. I'm finishing up my CDI class Tuesday and Thursday, and then I started an ICD-10 class Monday and Wednesday.
Okay.
So
Yeah.
my evenings are busy. Plus, working. Then I have tutoring after we finish today, so for sequel. So
All of the things going on, going on. Okay, okay. Well, she says she barely hears
she said it's
Jesse.
better.
Okay, okay. Um, so before we jump in, let me remind you that especially if you are on Clubhouse and you want to join in on the conversation, please raise your hand. Don't be, and this is for everybody, don't be shy. This is a conversation. Let's talk about this stuff. We want to get your opinion, and your opinion matters. And of course, it's always welcomed here. Whether it's a mutual agreeable opinion or not, it's still welcomed here. I learn from others and their perspectives and their point of view. So I am very, very much interested in knowing your perspective, especially today. So um for my YouTube, Facebook, and LinkedIn friends, you all know what to do. You use the comments or the chat function to place your comments. But if you have a question, please type a Q first so that we know it's a question and that we won't miss it. So let me see. And let's see. Wait a minute. Okay. Well, good morning, Miss Vicky, and thank you for the information about the sound. All right, all right. So a church announcement music. Yes. All right, all right. So our church announcements, our church announcements. I like that. The good old, it's called these jammy jams called Sad Sunday. I love it. I love it. Wait. The spirit done moved. He done went into the double tap, the double clap. Wait a minute. Hold up. Okay, so our church announcements for today. First things first. The ICD-10 PCS new codes from CMS. There's a document. They've been released. They've transitioned over the information, but the biggest takeaway from that, because some of them were from, as you know, we do everything twice a year now, April and October. So they've released some of the things that they want to do as it relates to PCS for October, but there are new coding guidelines for PCS. I'm trying to go through them to decipher what's new. They don't make it clear and easy like CM does. CM will tell you, if it's bolded, then this. They don't do that over here on PCS, where I don't know why. So you kind of got to do a comparison between what the ones before and the ones after to decipher what's what. But that's part of the church announcement. So that information is out. There is if you go to CMS website, and I think if you go into you can go multiple ways. Just do a Google search, ICD-10 PCS guidelines, and it'll take you to that CMS page, and you can click on the actual guidelines and look at them. And then you can also see the codes, the new codes as well. The other thing is that I wanted to bring to your attention. skilled nursing facilities. So if you code for skilled nursing facilities or have any involvement with skilled nursing facilities, CMS has now a 5-claim probe and educate review that's coming to a skilled nursing facility near you. They announced their 5-claim probe and educate review program, and they are doing this to lower the skilled nursing facility improper payment rate that Max are a part of. And so Max will be reviewing a small number, again, it's just 5 claims, from every Medicare billing SNF in the country. So I said they will be coming to a SNF or skilled nursing facility near you. The SNF will then be offered education to address any errors identified, helping them to avoid future claim denials and adjustment. They looked at the CERT comprehensive error rate testing program, and they projected an improper payment rate of 15.1% for SNF services in 2022, which was up from 2021. And it says that these errors were determined to be the top driver of the overall Medicare fee-for-service improper payment rate. And part of the reason for the significant increase in the improper payment rate may be misunderstanding by SNFs about how to bill appropriately, given the change from the resource utilization group to the PDPM, or patient-driven payment model. So there had been a change for these claims with data services on or after October 1st, 2019. And so they want to make sure that they are providing enough information to folks so that they understand what it means to submit their claims under the patient-driven payment model going forward. They want to do their due diligence, making sure that they let you know what's happening and what's going on. So it's going to be a similar to the current target, probe, and educate medical review that they currently do. It will provide one-on-one provider education at the completion of the small sample of claim reviews. It said instead of the 1 to 3 rounds of a review a provider receives through the targeted probe and educate program, each SNF will undergo only 1 round of review. So the MAX will review 5 claims for each SNF. The MAX will complete 1 round of probe and educate for each SNF. An education offered will be utilized based on the claim review errors identified in the probe. Review result letters will detail the denial rationales for each claim as appropriate. These reviews will commence on June 5th, so they are already in rotation, and will affect claims for services furnished after October 1st, 2019. Claims containing the COVID-19 diagnosis will be excluded from the review. And then there is, there's kind of more information on the CMS page under the skilled nursing facility 5-claim probe and educate review section. So there's a couple questions. And then there's a MedLearn Matters article on this as well, for you to take a look at if you need more additional information. And then they also, if you want details regarding the PDPM program, there's also a link for you to get that if you're, again, part of that skilled nursing facility group of folks. So that was that. The last thing is it's Juneteenth. It's Juneteenth weekend. And so I just wanted to kind of give, one, a little information. If you don't know, you've been, I guess, living under a rock or something about Juneteenth. And Juneteenth became a federal holiday in June of 2021 after decades, centuries of Black folks celebrating Juneteenth. It finally made its rounds to the federal holiday. I've been talking to people and they're like, well, we got to work. And I was like, well, first of all, every job they don't recognize every federal holiday, number one, depending on on the and how you work. We work in healthcare. Healthcare operates 24 hours a day, so you got to take that into consideration. But oftentimes they have floating holidays, so you get to choose what your floating holiday is. Sometimes people will float Martin Luther King holiday. Now you have Juneteenth as a floating holiday if you would like. But so Juneteenth is the actual commemoration of the end of slavery in the United States. And like I said, it's been celebrated for years and years and years, since the 1800s, by Black folks here in the United States. So let me just say this. We, the Black community, celebrate a lot. It it could be, let's throw the shirt up in the air day. We gonna celebrate. It could be all of the things. We're gonna celebrate it. We become Irish on St. Patrick's Day. We become Mexican for Cinco de Mayo. We do it all. Now, the people that I know who celebrate all the other heritages, we also do our due diligence. And so we make sure that we understand what those things are about. So we will not offend anybody while we're celebrating. I say this to say that some of the things that Black folks do on Juneteenth or during Juneteenth could be questionable for someone else to do outside of the family. Such as, it's my understanding that there's a lot of red food that is served. Red food, specifically watermelon. Now, we know we got a whole racial tension as it relates to watermelon and Black folks. Folks, if you are serving some watermelon at a Juneteenth gathering and say you're celebrating and you're going all in and you're doing, be mindful of the connotation and what that means to the folks that you may be inviting to your gathering. Know that folks carry phones everywhere. It could be recorded. You don't want that out there. So just be mindful of that. Do some research before you have that Juneteenth celebration. And you're not a cousin. Mr. Jesse, you have anything to say on that?
Okay, so I do want to quickly circle back to the PDPM.
Okay.
Because now, the fact that the sample size was only 5 reviews was not lost on me.
Right.
Because I'm like, that's a heck of an opportunity. Now, as somebody who works the inpatient PDI, then I see plenty of cases where people are discharged to the SNF. They are very complicated cases.
Uh-huh.
So I can see why it would only be 5 and you have to really go through it with a fine-tooth comb. But I just really, I think that it's once again another great opportunity for anybody in HIM who wants to branch into or like dip their big toe into entrepreneurship. Like these, the government doesn't do audits. They pay people to do audits. So it's a huge opportunity for, entrepreneurial minded HIM professionals to really kind of consider how to branch off, how to get, these contracts. And, so I wanted to say that, and also wanted to talk about this payment model. Because, I heard years ago, when I say years ago, I mean like 2015, that CMS was trying to change everything. When they came up with risk adjustment, they were trying to make everything risk adjustment, to have that payment methodology. And it took me a couple of years to realize, what, they have really done it. Because when you said PDPM, they did home health. They did home health around about the same time, and now home health has a PDGM model, and it's all centered around the ICD-10-CM code and the disease specificity. It's just really, really interesting how it's all playing out. That's all I wanted to say.
Yeah, and so it reminds me, when they say they're gonna do something, it may take a little time to get there, but they gonna do it. It's coming. And I saw I didn't want to talk about some of the OIG reports I got this week because Lord Jesus, there's one provider, he got hit over the head with some millions of dollars in repayment. I hadn't seen anything like that. I mean, for one provider, it's a lot. It was a whole lot. There was also a nurse practitioner out there doing some things too, but that was neither here nor there. So again, when they say they're coming, they're coming. When they say they're going to change something, they're going to change it. And yeah, they do actually get the buy-in from the stakeholders. So they part of what they do is they have those sessions where they put the proposed information out there, and then you have days, 60 days, I believe, to respond um, on questions or just your thoughts about what they're proposing, and then they'll come back and say, okay, we took all of these things into consideration. Either they go forward, they may pause it, or and regroup and get some additional information and research, or they may say thank you, but we're moving full steam ahead. So, but you have a voice. You have a voice in that. You have an opportunity to speak your piece. So when they drop those proposed rules, make sure you pay attention, especially if it's something that hits close to you and you got a say in it. Okay, now it's also Black Music Month. All the good music that we've been listening to and all of our little ads today. I thought I'd just throw that out there too. And it is Pride Month, which leads us to our discussion today about, are you being seen? That's really what we're going to talk about. Are you being seen? And let's talk equity and disparities via data. So if you're just joining us, even though we've been talking a lot about our church announcements, we're going to talk today about equity and disparities via data. So a few weeks ago, I hosted, I don't know if that's the right word, I guess I'll say hosted, my very first state association, AHIMA State Association meeting as president. And one thing that we do in our meetings is we have a section where we kind of talk about an environmental scan. An environmental scan, pretty much, we just ask the question, what are you seeing in your environments? Often our board is made up of, and I'm probably sure it's the same across the country, but our board is made up of people within the health information profession that encompass lots of areas. So we have those who are in management, we have consultants, we have those that are on the vendor side, we have those in education. I mean, they're all across the board and they're doing all kinds of things. And so we, take a few moments in our meeting just to kind of go through and discuss, well, what are you seeing? Or what are some of the hot topics that you are hearing related to health information? And it's happened that we began discussing, and we talked about it prior to our meeting in another meeting, but it carried over because AHIMA had recently released had a webinar talking about SOGI, and SOGI stands for Sexual Orientation and Gender Identity. And so they were talking about SOGI data and what that means. And so they had a webinar, they held a free webinar on June 1st talking about how the SOGI data helps a provider see the whole person. And so they had policymakers, health information professionals, and others. They kind of shared their pains and gains related to data, regulatory issues, and all of the things surrounding data. And it was a really it was a good conversation. Our conversation, what we took from that was this. While it's very, very important that these data elements are there, that we have data elements to fully describe people in the LGBTQIA plus, I think I got them all, community, because we all know that having that data allows us to then provide information where we can research any disparities, or we can understand what needs to be changed based on the data that we analyze. But of course, you have to capture that data first in order to be able to analyze that. And so, data is really can really be powerful in helping with advocacy, and helping with getting an understanding about things that need to be changed, or things that need to be moved. And so, again, this being Pride Month, and they are talking specific to sexual orientation and gender identity, they wanted to make sure that, one, there is a framework within the standard set of data elements that allows for SOGI data to be captured. And historically, they have put together it's called the U.S. Core Data for Interoperability, or USCDI. Sorry, I guess they pulled the CDI thing from y'all for short. Different CDI for short. And it's used to kind of support patient care and facilitate patient access. So again, it's just making sure that you have the appropriate data set or data elements within these certified health IT, EMR, all of the things related to data capture. But then it's gotten some movement and has shifted. So not only are they supposed to make sure that it captures data, but it also have been used. They have a version 2, and version 2 pushed it further to make sure that the data can be exchanged. And the only way that data can really be exchanged apples to apples is that everybody is on the same page and using the same elements. They have put together the definitions of what all of these things are and how they should be defined, and really who should be reporting the values. So most of this discussion or interaction happens at registration. And it's not up to the registrar to decide or determine what somebody's SOGI data is. It's up to the individual to tell them what their SOGI data is. And there's a lot of communication around training the registration professionals to make sure you ask. And it's like, you ask everybody across the board. You make no assumptions. You have that communication. The other thing is, and we had this in our discussion at our board meeting, but there's also ownership, as I mentioned, on the person receiving the care. So you have to be diligent in making sure that you express your SOGI data. You need to let folks know. And I think I'm gonna butcher it, but I believe there are at least 2 elements. One that mentions like the birth gender, and I don't mean to offend. If I am offending, I'm sorry. I think I'm trying to make sure I got the terminology right. The birth gender. And then I think it's the administrative gender. I think that was the other term. So the gender that you may identify as today. As health professionals, particularly, those who are adamant, and most of them should be adamant about making sure that they are caring for you, the whole person. It's to their advantage to know, who you were as well as who you are. Meaning, there are certain tests, there are certain procedures, there are certain things that that you may need depending on the organs that you may have. So, and one of the pieces in the video, they talk about the disparity of women who identify as lesbians, and they have lower rates of cervical cancer screening, which ultimately means they have higher rates of cervical cancer. And so instead of the blanket kind of population information and education of, you know, all women at a certain age should receive cervical cancer screening, the conversation should now become, because of the SOGI data and the times I guess we're in, and making sure that folks understand, if you have a cervix, you need to have a screening, period. So if you had a cervix, you were born with a cervix, that screening is still important for you, regardless of your how you identify today. And so, with that being said, the person who is seeking health care should also feel empowered or feel okay with sharing that information to the healthcare provider, so that they can make sure that they are doing everything to provide you the optimal care that you need, based, you know, as from an individual perspective versus a group perspective. And so I thought, which is why we decided to have this. This has been brewing for a week now. I thought this was a perfect time to talk about this during Pride Month. So while yes, we in the healthcare field have a responsibility, I think this is a great time for the people in the LGBTQIA plus community to also have this conversation on how they need to navigate through the healthcare system, what things they need to be prepared for, and the why behind, you know, why are they asking me this? Why are they wanting to know about, you know, who I was or how I was born? Why, what is this about? And that's primarily it. Another thing, and we talked about this too, was the services being reimbursed. So there are certain services that are tied to gender, and there are algorithms that are put in place that will check and say, well, if this is the gender that's being reported, and this is the service that is being reported that is specific to a gender, and if those things don't match, that kicks out, and that claim is then denied. And so I think there's also an opportunity for education to the community about making sure that they also notify and have the conversations with their insurance carrier about, you know, the SOGI data as well, so that keeps the flow of the revenue cycle going, and kind of stop some of the denials that could potentially happen because the information isn't complete. And you all know we're all about making sure documentation and information is complete for our perspective. That's primarily what we do. Mr. Jesse, did you want to jump in?
I just wanted to jump in and say that the trans community has been at the forefront of this for a while, because they have been most impacted by healthcare disparity. And there's a woman, Valerie Spencer, who talked about this, like, I don't want to say 10 years ago.
Mm-hmm.
And I think now she's a social worker in California. And, you know, she talked about care and how, even if you're trans, you still need to have certain healthcare screening. So I think that, and the problem also comes in with because I don't think anybody trans is in denial about the fact that they still have certain anatomical parts. I think that the problem with them is receiving, you know, affirming respectable care.
Mhm.
You know, for somebody to respect their, you know, their gender identity and not still provide a service, but not um, dehumanize their experience. So I think that's really, you know, what is that the underbelly of all this, just gender affirming care.
Mhm.
Because I think that's what's important.
I agree. I agree. And I think so on the hospital or at the organization level, and this is really even bigger than just the LGBTQIA plus community. It's across the board. You know, checking your biases at the door and having the education and understanding of that everybody is not like you. Everybody's walk of life is different. Everybody doesn't look like you. Everybody doesn't act like you. Everybody doesn't operate like you. And being respectful um, of those differences, but also treating people with the utmost respect and treating people. I mean, it's the golden rule: treat people as you would want to be treated. Um, period.
I agree. And being since I've been a nurse for, you know, now 30 years, I can tell you that in anybody who works in healthcare is trained in addressing your biases. That's part of your education. But people still have biases. And
Mm-hmm.
I mean, I clearly remember not you know, not so much now, but you know, during the 90s, you know, when AIDS was really, you know, still, you know, at the forefront,
Mm-hmm.
you know, I used to hear um, nurses in report talking about somebody having, you know, the condition, and then, you know, some people want to know, well, how did they get it? What does it matter?
Right.
Because you want to pass judgment. That's really what it is.
Right.
Because when we take care of people who are like when somebody comes into the hospital because they didn't take their diabetic medicine, you don't shun them.
Right.
You know, there's not any kind of real, you know, value judgment about that. Oh, well, you know, you need to take, you know, your insulin. You know, you need to take your metformin. That's about as far as it goes. But you don't receive substandard care because you didn't take care of them because you didn't follow directions. But we all know that when there's certain conditions and certain segments of the population, including Black people, we do um, receive substandard treatment a lot of times.
Mm-hmm. Mm-hmm. And I think you hit it on the head with the whole value judgment um, component. I think that's where it hits. And when you mentioned that, I thought about um, I thought about the religious hospitals or organizations that we have, and um, how the value judgment that could potentially be part of that culture, especially as we move through the years. I mean, of course, folks are retiring and moving off, and whatever. But I think that's something to consider, and I wonder how that is handled or approached in some of those entities. Now, I know there's, at least my understanding is, there's guidance, just like, especially with any federal, if you're receiving any federal dollars, regardless of any of that, these are the things that you need to make sure that happens, and uh, providing care to your patients, care that is equitable, and all of those things. Providing that care is what's required. So I'm curious as to what those kind of conversations, and I know oftentimes, well, I know they actually have the same EMR systems that a lot of folks have, and so those elements are part of that. And so again, I'm curious as to what that looks like, or if there's any change, and it may not be anything different in those institutions. I'm just curious.
But I also think that if you are in a marginalized community, you know not to go to those places. So a lot of people they wouldn't even go because they know what they're going to get.
That's true. And again, that's part of, I think the education that the community should have. They're like, we used to have that green book that tells you where to go, not to go, where to, something similar for them as they navigate through the healthcare community should be warranted for them as well. So hopefully they have something, or have the discussions. If they're plugged in, have the discussions, and then getting everybody plugged in so that they know. Yeah. Did you get a chance to watch the video?
No.
No. It was good. It was good. Yeah, I don't see y'all quiet today. I don't see nobody. Look, I wanted to know what the folks was thinking about this. Yeah. So then the other thing, I guess, was and this was old, but this played into kind of our conversation about Florida. DeSantis sent a survey to state universities requesting the number of students who sought or received gender affirming treatment. And he sent it to all of, I believe it was the presidents of the universities. And so we kind of had a discussion, like, why? What was the the why? And is that the right thing to do? Is that, is that disclosure necessary? Is that disclosure, can that disclosure be harmful? Can that disclosure kind of identify a set group of people in a set area? Like, what we thought about the harms that all of that can possibly do versus any gains, I guess. And I think we were all in agreement that coming from the source that there were a lot of harms that could happen. And it says that the survey requires breakdowns by age, regardless of whether students are 18 or older, of people prescribed hormones or hormone antagonists, or who underwent medical procedures like mastectomies, breast augmentation, or removal and reconstruction of genitals. So they were trying to get a lot of information from the state universities, and they were forcing them to complete these surveys. Yeah. So it's like Florida's doing a whole lot, and it's scary. And I don't know if there were other states that have kind of followed this lead or not. But yeah, this was. No, go ahead.
I think that people have to be careful because people might think that this is, it doesn't really affect me, but it does.
It does.
Because we've heard it all our lives. History repeats itself. And history repeats itself because people don't learn. And they always, when I say they, I mean the system, the powers that be, they always come after marginalized groups first that nobody cares about.
Yeah.
Because today it's have you had are you receiving hormones? They want to know. Okay, well, I'm not taking hormones. I don't care what you're taking hormones. You shouldn't be afraid. You shouldn't be ashamed to say it. That's until you want to hide the fact that you had an abortion last Saturday.
Mm.
And you have to go to the campus nurse because you're having bleeding. See, it's okay until it comes to your front door because it's coming. It's the trans community today, but it's going to be women tomorrow. And it's going to be everybody else the day after.
Right.
Trust me.
Right. And to your point, you have to think through that and know that while it may not be you today, it may be you tomorrow, and could have been you yesterday. You just didn't know, or you didn't consider. Yeah. So it was a lot. It's a lot of discussion around the whole data things, and we at as health information professionals, we are data experts. We pride ourselves on making sure that we get the data that's needed to advance healthcare practices, advance research, advance kind of all of the things. Because if you think about it, even with capturing and documenting the social determinants of health, we're advancing, policies and legislation. We have a hand in that, as long as we are capturing that information and making sure that information is complete. That's where folks go to kind of do their research to determine, which their strategies for some of this information. So, we're right there at the forefront, making sure that this stuff is captured. But again, go ahead. Oh, but again, we have to be forthcoming and, let folks know, hey, this is one of the things they talked about in the webinar was with race and ethnicity, and how years ago it was kind of just black, white, or other, and you didn't have the diversity that we all know that exists. You didn't have a field to kind of really nail down the diversity of the people that was receiving care at certain facilities. Well, now that those data elements have been expanded and you have a lot, and you're not just lumped into an other, that you can drill down and you can see, and we know that there are health disparities based on race. So you can drill down that data because that data has been captured. You can drill down and show and see for certain this is a health disparity. One of the things that I remember dealing with a provider in the healthcare compliance community, and he deals with colon health, and I think it's a gastroenterologist, but he also was a huge proponent of lowering the colonoscopy screening age. And he had been talking about this for years and years, particularly among the African American community, because he said once they get the diagnosis, oftentimes, especially if they're doing that screening at age 50, 55, it's too late. It's usually so far advanced that there's really, it could have been avoided had the screening occurred years earlier. And so he was such a proponent of having that screening for African Americans at age 45, which they have now changed. And again, all of that is based on the data. All of that is based on having the data to show the disparities. What has happened had this screening happened earlier? These outcomes may not necessarily exist. So again, having and being able to collect this information, making sure it's complete, having the diversity of the information, because I'm sure years from now, there will be a need to kind of even further slice and dice this data to look at some possible disparities and or health outcomes for this particular community. And the only way that they will be able to do that and do that with accuracy is to have those elements further identified and diversified.
Then I just wanted to come back to the point that we were talking about data, especially when you think about it in terms of, because I want to go back to the whole, state university thing. Do you know how many students go to state university? Like, you have main campuses, like I think Penn State, like their main campus is in the middle of nowhere, but their main campus has I think it's 40,000 students. That's a lot of data.
That's a lot of data.
And a lot of them are going to their campus health center.
Mm-hmm.
Because they don't know there's nowhere else for them to go.
Mm-hmm.
So they don't know that there's another provider, 2 towns over there. It's basically an enclosed community. So they're going there for pretty much everything.
And they may not have insurance. They just have the insurance that they get through the school. So they know they're insured while they're a student of the school, and they can easily get care right there on the campus.
And so it's a lot of information that they want to be able to rifle through, and I don't think they should be allowed to, because it's a slippery slope.
It's a very slippery slope. I think some of the conversation around that was because of there was election talk and targeting these marginalized groups during, kind of for the election. And that was kind of the focus, like, is that right? Should they be doing that? Can they do this? All of the things. And so that was also part of those discussions and conversations that we had. So it was real interesting. It was real interesting. So yeah, you know that, don't be in your feelings or feel some kind of way if you are asked certain questions. It's for you. It's to help you in making sure that you get the best individualized care that's available. So if that's any takeaway, that will be the takeaway for the day. And that the data can help. The data can help kind of because the data is the data. It is what it is. Everybody can have their opinion about this, then the third, but data is the data, and it can show what some of those health inequities and disparities are, and then allow for some policy making to reverse those. So yeah, I think it's a great thing, but just like when a lot of Black folks still, you will hear all the time, well, I don't want to be involved. Well, that's a whole other conversation, but I don't want to be involved in research because of, the Tuskegee experiment. And so they shy away from that, or they won't participate. However, it kind of hurts because you don't know what you don't know, because you don't have that population represented in some of the research that occurs. I think we saw a lot of that during COVID, where there were questions about, the racial makeup of an individual and how the effects of COVID, what the outcome of that was. And even when they did there were clinical trials, they were swift and quick, but there were some clinical trials related to, vaccination and stuff. You didn't have a lot of folks that represented various ethnicities as part of those trials. And so it becomes to me a circular conversation, because it's like, well, if we had more of the folks here, then maybe we could see, but then you don't want to do it because you're scared because of this, and it's a whole convoluted mess. And I think at some point, everybody just needs to be real about the why. Be real about the why. So Mr.
But the thing is, well, they know why. It's just they don't want to do anything to change it because it works for them. You know, I mean, yeah, no, 'cause it gets very, very deep.
I know. See, I feel here we are again at a low point. But again, the information matters. Data matters. That whole health IT, they were talking about SNOMED, CT, and when they were talking about all of the different things, I'm thinking about you, like, we got a man who's over here learning all of this stuff and becoming the data analyst and getting the information on how to be able to do the research and to slice and dice the data that we provide. And I mean, it's so much. And we've been talking about, or folks have been talking about, like AI and all of the things. And again, the quality of the data that's in there will help with the quality of the information that is coming out. Because garbage in, garbage out. We ain't trying to hide garbage. We're trying to get the good stuff in there, making sure that it's not only good but also complete and accurate. And that's our job as health information professionals. So that was a lighter note. I tried to turn it around. I tried it. All right. Well, we are at the top of the hour. Y'all been real quiet today. Yeah, I don't think I had anything. Did you see anything else? Did you have anything else you wanted for the good of the order? All right. Well, we're gonna give y'all some time back. We'll definitely have our little meeting after the meeting. Well, thank you all for joining the Saturday morning tea today. Let's see, was the tea spilled? It was spilled to me because I learned a lot just watching and understanding CHC. I had never heard that term before. Before seeing the article and seeing the webinar, I said, "Oh, I done learned something new." CHC, okay. We love.
It's definitely an evolving process.
Yes, and we love acronyms, so you got to stay on top of them. We love acronyms. And then the SNF thing too. That was real important because oftentimes you don't hear about other entities being part of the reviews, and I think this is a great opportunity for. I don't know, 5 charts. I know you can see a lot in 5 charts. I think it's going to expand and open up a bigger can of worms, but at least let's start, uncovering some things so that you can go deeper and get.
But also, but the reason why I think you only need 5 is because, believe it or not, you know how many people, because I've had cases like this, you know how many people are discharged to SNF and then readmitted to the hospital a week later, days later?
Oh, it's a lot. It's a lot. Yeah, I think that even though with those 5, that the possibility of them then having additional target, probe, and educate reviews can open up, which will be helpful. So I think, yeah, like I said, this is just kind of scratching the surface and just getting an understanding. You're getting your benchmark. You're learning to see, what you can see and what you can find. So I think it'll be helpful. Hopefully you don't see a whole bunch of other foods and stuff. The SNFs, boy. Ooh, we talked a little bit about that before, and hopefully it will help with the some of the things that are happening over there in the SNF world. I'll say it that way. And information that they will glean from these chart reviews will benefit all. There will be good outcomes as a result. I'm encouraged, if nothing else, that can happen. I'll say it that way. If this information was valuable for you, help us share this message with others by sharing the video and subscribing to the Professional Reimbursement Network channel. And don't forget, as you leave, to hit the thumbs up or like button. You can also check out the Coding Nurse channel on YouTube and subscribe and like some of the content that you find over there as well. Last but certainly not least, we want those of you on Clubhouse to feel free to be part of our house, where you will get notification of our live broadcast, which occurs every Saturday morning at 9 a.m. Eastern Daylight Savings Time. So again, this has been a great session today. Thank you all for joining. I've been real quiet, but it's okay. The information got out. The tea was spilled. And so thank you for joining and taking a few moments out of your day. Vicki said, yes, it has been some informative tea. All right. We appreciate that. Remember, be safe, be kind, and don't wish for it, work for it. Until next time, take care. Have a great one.